My name is Sarah Updegraff, and I'm doing a presentation on testicular torsion. For subjective information, the patient's chief complaint is my left ball really hurts, my belly hurts, and I'm nauseous and throwing up. For HPI, we have an 18-year-old white male who presents to the office with complaints of severe left scrotal pain radiating to the abdomen, nausea and vomiting intermittently for approximately 2 days. Nausea and vomiting started first, and then he's had about 4 brief 2 to 3 minute episodes of acute scrotal pain, nausea and vomiting in the last 48 hours that then resolved. The most recent acute episode started abruptly, again about 1 hour ago, and is unremitting. He denies fever and chills and states that he has not taken any medication. For GI, we've talked about he's reported his nausea and vomiting and abdominal pain, and that's been constant for the last hour, and he denies all other GI symptoms. For GU, reports severe left scrotal pain and says that he's had redness and swelling. He denies all other GU complaints. And for psychosocial, he reports feeling very anxious due to pain. For subjective past medical history, he had a history of chronic ear infections as a child. For surgical history, had tubes placed in his ears when he was about 2 years old. For past injuries, he reports none, and he denies any recent injury to his groin. For social and psychosocial history, he lives at home with his parents, is taking classes at a local college, and works at a grocery store. Denies alcohol or illicit drug use, states that he smokes cigarettes recreationally and less than 10 cigarettes a week. He reports that he is not normally anxious, but is feeling very anxious today and has no past mental health issues. For reproductive health, he's not sexually active and has no history of STI. For allergies, no known drug allergies, but he does report seasonal allergies in the spring. For medications, no current regular medications, occasional use of acetaminophen, and Claritin use for allergies in the spring, but not taking at this time. His family history is non-contributory. So now we'll move on to his focused exam. For his vital signs, his respiratory rate is slightly elevated, but everything else is pretty normal. He presents as a thin white male appearing younger than his stated age. He appears to be in acute distress, grimacing, guarding, breathing somewhat rapidly, and moaning. His skin appears to be slightly pale and slightly diaphoretic. You can see his heart rate is like a little bit elevated. His blood pressure might be a little bit high, probably because he is in pain. Okay, so now for our focused exam. His assessment of his heart is normal, unremarkable. Lungs, his breaths are slightly shallow and the respiratory rate slightly elevated, but otherwise unremarkable. Abdomen is unremarkable except for the pain, the radiated pain in the abdomen and tenderness. For GU, he's got no bladder distension, flank pain, or CVA tenderness. His penis exam was normal. Now we get to the meat of what we're doing here, and we look at the testes and the scrotum. So we've got no scrotal lesions, and then we're going to look at the right testes. It's located on the horizontal axis, no edema, redness, lesions, nodules, or irregularities noted, and the cremasteric reflex is positive. On the left, we find moderate scrotal erythema and edema, no lesions or nodules. The testes is located high in the scrotum and also on the horizontal axis. 10 out of 10 pain, more severe upon palpation, a negative Pren sign. Patient is unable to localize the pain and appreciate a firm tender mass on the left scrotum above the testicle and an absent cremasteric reflex on the left side. No blue dot sign noted and no lymphadenopathy noted. It's important to be aware of the characteristic of the pain and the patient's ability to locate, because diffuse pain suggests spermatic cord torsion, whereas torsion of the testicular appendages presents with early focal tenderness at the superior pole of the epididymitis. And epididymitis also usually has pain that is localized anatomically. So those are two other things that we're thinking about here Here's our diagnosis: acute testicular pain, nausea and vomiting, and abdominal pain. There's a long list of differential diagnoses. I am not going to read all of these. Our main differential diagnoses at this point are testicular torsion of the spermatic cord, torsion of the testicular appendages, acute epididymitis, epididymo-orchitis, possibly incarcerated hernia, although the physical exam findings didn't find anything that would support that. I found this table here in one of the articles that I used to prepare this presentation that has a very nice breakdown of clinical features for if you're trying to decide between these three main diagnoses. So you can see where our patient falls. You know, he's past puberty, so he's going to fall into the age under testicular torsion that's most common, also under epididymo-orchitis. But then you look at the onset of symptoms, acute. So our patient had acute onset, usually with torsion of the testicular appendage or epididymo-orchitis that were subacute. The site of maximal tenderness, like I said, it can be more localized in the other two, and with testicular torsion tends to be diffuse. The cremasteric reflex, this is the big one. This being absent is a very big red flag, absent on one side. And other findings include the high riding swollen testes, which this patient also had. So we're really thinking that's what's going on here. Here's our diagnostic statement. He's an 18-year-old boy with acute and previously intermittent testicular pain, nausea and vomiting, and abdominal pain who presents with an erythematous, edematous, asymmetrically palpated left testicle and an absent cremasteric reflex in the left scrotum. Here are our ICD-10 codes. We've got testicular pain, nausea with vomiting, and abdominal pain, generalized. The other two are unspecified. Then we have torsion of the testes, unspecified, but you cannot diagnose this based on physical exam alone. They would confirm that in surgery. So our number one suspect here is testicular torsion. That is when the spermatic cord twists and obstructs venous return in the testicle, which can result in compromised arterial blood flow and ischemia. As far as etiology goes, this is not often precipitated by an event, although it can be. In our patient, it was not precipitated by an event, according to him. It's most common during the neonatal interval or during puberty. As far as pathophysiology, torsion can be extravaginal or intravaginal, but intravaginal is much more typical during puberty. And our patient also looks younger than his stated age, so maybe he's a late bloomer, which would sort of put up a red flag as well. Venous return is obstructed first, and then as venous and arterial pressures equalize, ischemia results. And the extent of the ischemia is related to the degree of spermatic cord rotation and the duration of the symptoms. Intermittent torsion is possible and can progress into full torsion, which is probably what's happening here, which is why he was having those episodes over 2 days, and now he's in the more acute full testicular torsion. So here's just a picture sort of explaining what that looks like. You can see the spermatic cord is twisted in the testicular torsion, whereas in the normal, it's straight. And that can be that mass that you might appreciate when you're doing your exam. Risk factors include the bell clapper deformity or testicle with a horizontal lie, which our patient had, a testicular volume increase as in puberty, which perhaps our patient is going through now, testicular tumor, history of recurrent episodes of testicular pain, which he did report, a history of undescended testes, and a long intrascrotal spermatic cord. Here we'll take a look at prevalence and common symptoms. Can be 1 in 4,000 males under 25 or 3.8 in 100,000 under 18, just depends on how it is measured. These are two different ways of measuring. Common symptoms include intense scrotal pain, nausea and vomiting, and abdominal pain. Those are just what our patient presented with, so not big surprise. Here's our diagnosis. Careful H&P that suggests testicular torsion warrant an immediate referral. Diagnosis is confirmed at the time of surgical exploration. Doppler ultrasound can be performed by the practitioner, but only if it does not delay referral to surgery. Doppler and grayscale ultrasound will show decreased blood flow in the torus testicle. And I've included a picture here so that you can see on the one side there is reduced blood flow compared to the other. The Doppler ultrasound is important when you're not quite sure if this patient is having epididymitis or testicular torsion or perhaps a testicular infarction. But with epididymitis, you're going to see increased blood flow to the affected side during the Doppler ultrasound. And in testicular infarction, you may find a wedge-shaped avascular focal area. So this is to give the practitioner a little bit more information if they need, and only if they can do it quickly. Scintigraphy or dynamic contrast enhanced MRI are slower and less available, but as good as ultrasound, or you can do radionucleotide scrotal imaging. These are not commonly done. Usually it's the Doppler ultrasound or just a direct referral without one. The urinalysis is usually unremarkable. So this is another thing you'd look at if you were trying to think, could this be epididymitis or could this be testicular torsion? Usually epididymitis will have a positive urine analysis. Here are some evidence and guidelines regarding manual detorsion. It can be attempted in addition to prompt referral. The Lindblom and Ringdahl guideline is to attempt detorsion to help support diagnosis before referral. If detorsion relieves pain, then that's definitely want to refer. Hollier guideline recommends manual detorsion if surgery is not available in fewer than 6 hours, and Dynamed Plus and the Sharp and Kieran recommend manual detorsion only if it does not delay surgical treatment. And here's a picture of how you do manual detorsion. You do it like opening a book. So if your patient reports a lot of increased pain when you start to do that, you should just stop. But if they report reduced pain, then that's a good sign or a bad sign that it's testicular torsion. So here we have our management plan. Our working diagnoses are with just the testicular and abdominal pain and nausea and vomiting. For our plans, the pain control is kind of tricky because you can give analgesic medication for testicular pain and abdominal pain, but that's not generally done in the primary care setting. Usually the correcting the torsion is what stops the pain. You can use a local anesthesia if you attempt manual detorsion. Antiemetics can be given to reduce nausea and vomiting, but these are also not usually given in the PCP setting because you want to get this patient out as quick as possible. Here are two algorithms that you can look at. The first is from Essential Evidence Plus. So we can look at that our patient, you start up in the yellow box here. Do they have a history of recent trauma? No, we didn't see that. The cremasteric reflex present? No. So then you go to manual detorsion resulting in the immediate relief of pain. If you go yes, then the urologic consultation to consider future surgery. And if you go no, then they suggest doing a Doppler ultrasound or a scintigraphy if it's readily available and doesn't delay treatment. And if that doesn't show anything, then you're looking at emergent urological consultation for torsion. On the other side, they're a lot more kind of cut and dry, where if you Sharp and Kieran see if you have your history and physical and it's just highly suggestive, you just get them out of there. And that's kind of the route that I'm going to go here because my patient seems to have pretty clear symptoms. You can see though on theirs, if the diagnosis is questionable, that's when you want to check out the Doppler ultrasound to see what could be going on. Get a little bit more information that way. So here's for referral and follow-up. Of course, we've talked about immediate referral. Surgery is the only definitive treatment. The follow-up plan would be to see your urologist in 1 to 2 weeks post-surgery, annual wellness visits, checking GU health, and patient education to seek care immediately if symptoms occur or if he has any signs or symptoms of infection or anything post-operatively. Here we have health promotion and prevention. This is kind of an unexciting slide because there really aren't any lifestyle changes or ways of preventing testicular torsion other than providing education to ensure prompt action on part of the patient. There's no complementary therapy or diet changes or OT or PT. Mostly, we're just going to talk about education. At the time of informed consent for surgery, the patient would need some counseling for the potential need for orchiectomy, information regarding the fixation of both testes and what to expect with the surgery, and possible issues with future fertility or atrophy of testes. You'd want to discuss risk factors and complications. For example, our patient seems to have the bell clapper deformity, which puts him at higher risk. And he should know that 66% of salvaged testicles may show atrophy in 2 to 3 years. You'll want him to be educated about early recognition, as well as know about his prognosis. The salvage rate is 90% if within 6 hours, drops to 50% within 12 hours, and less than 10% after 24 hours. In this case, since his acute unremitting episode has only lasted for an hour, his prognosis should be pretty good as long as we can get him there as soon as possible. Even though he's had symptoms over the last 2 days, they haven't been unremitting. They've been a few isolated, kind of intermittent torsion. Complications he would need to know about are testicular ischemia and impaired fertility, as well as recurrent torsion and psychological distress. Here are some treatment guidelines. There's a list of resources on one side. Pretty much all the recommendations recommend emergent referral to the ED, urology, or surgery if testicular torsion is suspected. All guidelines recommend Doppler ultrasound or any other imaging only if treatment is not delayed. Because you really, time is testicle. You really want to move fast when you get these patients. This is an example of an order for a Doppler ultrasound. But in this case, I probably would not actually write one for my patient because he's got pretty clear symptoms, and especially with his history of intermittent torsion, even if my ultrasound didn't show anything exciting, I would be sending him to surgery right away anyway because of the high degree of clinical suspicion for testicular torsion. So I would not actually write an order for a Doppler ultrasound, but I'll put this in as an example so that you can see what it should look like if I weren't sure what his diagnosis was. And then here are my references. Thank you so much. What it should look like if I weren't sure. My name is Sarah Eptigraph, and I'm doing a presentation on testicular torsion. For subjective information, the patient's chief complaint is my left ball really hurts, my belly hurts, and I'm nauseous and throwing up. For HPI, we have an 18-year-old white male who presents to the office with complaints of severe left scrotal pain radiating to the abdomen, nausea and vomiting intermittently for approximately 2 days. Nausea and vomiting started first, and then he's had about 4 brief 2 to 3 minute episodes of acute scrotal pain, nausea and vomiting in the last 48 hours that then resolved. The most recent acute episode started abruptly, again, about 1 hour ago and is unremitting. He denies fever and chills and states that he has not taken any medication. For GI, we've talked about he's reported his nausea and vomiting and abdominal pain, and that's been constant for the last hour, and he denies all other GI symptoms.